Good evening, everyone. I'm Genevieve. I'm from the Menopause Hub, and I'll be presenting this evening on menopause, HRT, and other treatment options. So a quick overview of what I'll be discussing this evening. We'll go through some definitions. We'll go through the symptoms of menopause and perimenopause, and then I'll be looking at HRT and HRT alternatives. So just to start with some definitions that we're all on the same page. I thought I'll start with the hormone because it's a word that gets thrown a lot. Women tend to feel like we're ruled by our hormones. It's important to know what it is. So a hormone is essentially a chemical messenger that's released from one part of the body, sends a message to another part of the body, and an effect is created. So, for example, FSH, which is follicle stimulating hormone, is released by the brain. It sends a signal to the ovary to release an egg, and ovulation happens. Now, perimenopause, menopause, postmenopause, again, words we hear a lot, and especially at the moment, we're hearing a lot of. It's helpful to know exactly what all these different terms mean. So I'll start with menopause. Menopause is essentially the end of a woman's reproductive life cycle. So it's when she stops her periods, she stops ovulating, and because she's no longer ovulating, her estrogen levels drop quite significantly. And it's really the drop in estrogen which causes symptoms of menopause. For most women, menopause happens at around 51, and the average duration of symptoms, depending on various factors, is around 7 years. Now, perimenopause is the lead up to menopause. Women tend to still be having periods at this time, but they start to become erratic. We see a lot of hormonal fluctuations, and the changes in these hormones account for symptoms. For most women, perimenopause starts at around 45. And then postmenopause is the period of time where you've then gone through your perimenopause, you've gone through your menopause, and you go into a phase where you are no longer symptomatic. So you're still not having periods, you're still low in estrogen, but you're no longer symptomatic because of the low estrogen. And then HRT or MHT, the terms are used interchangeably. So HRT is hormone replacement therapy, MHT is menopause hormone therapy. And really the mainstay of hormone replacement therapy is estrogen. As I said earlier, it's the loss of estrogen in menopause which causes symptoms. So by replacing the estrogen, that helps to improve the symptoms. And then depending on whether or not a woman still has a uterus, a progestogen is added alongside that. So what are some of the symptoms of perimenopause and menopause? I think many of us know or associate menopause with hot flashes and night sweats. And while those are definitely the kind of classic symptoms, there are over 40 different symptoms of perimenopause and menopause. I tend to break them up into physical, mental and emotional, and genitourinary symptoms. It just helps, the division makes it a bit easier to go through everything. So physical symptoms, as I mentioned earlier, those include your hot flashes and night sweats. And then around the perimenopause, we see irregular periods so that your cycle could become shorter or longer. And it's often a time when women experience heavier periods as well. It has to do with the fact that if you're not having a cycle where you've ovulated, it means that the lining of the uterus builds up over one or more cycles. And so then we start to see these really heavy periods. And that can be very bothersome for women. Around this time, we start to see a change in sleep as well. Sleep can be disturbed by night sweats, or in women who are not having night sweats, they could still have poor sleep. The kind of typical pattern that patients would describe to me is that they're exhausted, they get into bed, they fall asleep straight away, but come 2, 3 o'clock in the morning, wide awake, mind is racing, they kind of can't, they toss and turn, can't go back to sleep until half an hour before the alarm goes off, and they wake up feeling exhausted. So again, fatigue, a really common symptom. It could be due to lack of sleep, but could be simply due to the changes or loss of estrogen as well. Joint aches and stiffness is a really common symptom as well, and various musculoskeletal complaints, which Ruth had mentioned earlier. Dry eyes and changes in hair, skin, and nails. We have lots of estrogen receptors all over the body, including, in places where we produce fluid, so our mucosa of our eyes, our mouth, vagina, bladder. So we often see things like dry eyes and dry mouth around this time. And then, like I said, dry skin, hair, nails, things like that. Bloating and weight gain, really common as well. The weight gain is very multifactorial. It could be due to the fact that, you are tired, you're not sleeping as well, you're achy, you're sore, you're not exercising as much, you might be reaching for different kind of comforting foods. But there are hormonal aspects as well, which make women more prone to gaining weight and kind of changing body shape at this time. We see women tend to gain weight around the middle and lose the waist. That's quite typical of changes in estrogen. Breast tenderness is more of a perimenopausal symptom, and that's to do with the fluctuating hormones. Now, not to be overlooked are the mental and emotional symptoms. These can be quite significant for a lot of women. Women who have a pre-existing history of anxiety or depression are prone to this getting worse around perimenopause and menopause, but we also know that women can experience new onset mood changes around this time as well. And that can range from anything from feeling, low, flat, or depressed to having mood swings, especially before period, a lot of irritability, rage, anxiety, feeling overwhelmed, loss of confidence, and brain fog. This is a really common symptom and one which is very concerning for a lot of women. Because the brain has so many estrogen receptors, when we're having all these fluctuating hormone levels or the estrogen drops off, the brain needs to work a bit harder. And one of the things that we typically see around this time, around the kind of brain fog, is issues with verbal memory. So women will struggle to remember the names of people or words of things, even though they know exactly what it is, they can't get the word out. Or they might forget what people have told them. And as I said, this can be very concerning. A lot of women will come to me and say, could I have early Alzheimer's or dementia? And brain fog is not a precursor for that. It is concerning, but it's temporary. And like I said, not a risk factor for Alzheimer's or dementia. And then lastly, the genitourinary symptoms. As I mentioned earlier, because we have so many estrogen receptors along mucosa, including the vagina, vaginal dryness is a very common symptom. And this can lead to pain during intercourse as well. We see a lot of bladder issues, so urgency, frequency, incontinence and leaking, and recurrent UTIs as well, and low libido. The genitourinary symptoms are often symptoms women don't want to talk about, but it's important. They can be very bothersome and uncomfortable. And so if you're having those issues, they need to be addressed alongside the physical and emotional issues. So, this leads on to, if you're having symptoms, how do we treat them? And this is where HRT starts to come in and we start to have a conversation about it. So as I mentioned earlier, menopause is it's the end of a woman's reproductive life cycle. It's a very natural phase of a woman's life. It's not a disease to be treated, but because these symptoms for many women are really distressing and significantly impact all areas of her life, she's looking for some form of treatment. And we know that HRT is the most effective way to treat these symptoms. Now, HRT has come quite a long way. It has been kind of very good, very bad. Now we're somewhere in between. Looking at the heyday of HRT, HRT was actually first released to market in the 1940s, and that was Premarin, which is the conjugated equine estrogen. It was estrogen which came from pregnant mare's urine. That's where Premarin comes from, the name. But it was really in around the 1960s where it really picked up steam. There was a book published by a man and supported by Big Pharma, and there was a lot of messaging around the benefits of HRT in keeping women kind of young and sexy and healthy. It makes women more pleasant, and husbands were very grateful for this. And there was very much the narrative that menopause is a hormone deficiency disease and should be treated with HRT. And so between the 1960s and the 2000s, there was a massive uptake in prescriptions of HRT. Many women were on it, and it was only around the early 2000s when a study which had been going on for a few years, the results of which were published, which was called the Women's Health Initiative. The results of that study were quite alarming in that they noted a significant increase in breast cancer, clot, heart disease, stroke, things like that. There are a lot of issues with that study. We know now that the patient population that study was done on was probably not reflective of women who are actually in menopause. The type of HRT that they used and the doses were quite different, and the way that the data was interpreted and released to the public was incorrect. So there were a lot of issues with that study. But with that messaging, we started saying, don't take HRT. A lot of doctors stopped prescribing it. A lot of women stopped taking it. And so having seen this big rise in HRT use in the 1960s up until the early 2000s, we then saw a big drop off. And if women were prescribed it, they were told, you can only take it for a short time, you have to stop it at 60. There was a lot of fear around HRT. Now going into kind of 2020 and above, there's a lot more conversation around menopause and HRT. A lot more women are understanding that, if they have symptoms, they should be offered something to treat those symptoms. We have more data and information now about HRT, and we know that it's a lot safer than it was kind of published in the early 2000s. We have different types of HRT, different doses, a lot more kind of patient prescribing guidelines. So we feel very comfortable prescribing HRT now, but myths still exist. Women still worry about, you can only take HRT if you have severe symptoms. Only if it's really bad do you take it. If you have a family history of breast cancer, you can't take it. HRT might cause dementia, might prevent dementia. There's still a lot of conversation and a lot of uncertainties for women around HRT. And I think the role of your healthcare provider should be to reassure you around HRT and to prescribe it if you're having symptoms so that you can feel better. So as I mentioned earlier, we have a lot more safety data, more treatment options, better guidelines, better access to information. I think this is really important. Women now feel a lot more empowered to, go to their doctor armed with information and symptoms, and does have a discussion about HRT and menopause. And so we have more patient advocacy and autonomy as well. So if you have to Google what is HRT, it can be a bit of a minefield because they're all different types and subcategories of HRT. So as I mentioned earlier, HRT is hormone replacement therapy. We're giving you exogenous hormones, so external hormones to replace internal hormones and treat symptoms. HRT can be broken down into various different categories, as I've outlined here. So the first category, which I'll go through, is synthetic versus bioidentical. So bioidentical is a term which you might have heard of. It's kind of the big term in HRT at the moment. A bioidentical hormone essentially means a hormone which looks almost identical to your own natural hormones. And in theory, it's then better tolerated from a side effect perspective and possibly lower risk. A synthetic hormone is one which is made in a laboratory. It has a similar structure, but not an identical structure. Synthetic doesn't mean bad. The oral contraceptive, many of them are synthetic hormones, and women, have relied on an oral contraceptive for many years, and it's, been a great medication for a lot of women. But what we do see with synthetic versus bioidenticals are often better tolerated, but it certainly doesn't mean that they are better. It very much depends on the woman and what her aims of treatment are. In terms of bioidentical, there is a bit of an overlap in that there's also something called compounded bioidentical HRT. So this means HRT, which is made in private pharmaceutical kind of laboratories. The doses are made up according to the patient's blood results. It's not something which is endorsed by the menopause societies. They would very much recommend going with pharmaceutical grade bioidentical hormones rather than the compounded hormones. Now, oral versus transdermal, again, something which has come to market fairly recently are these transdermal hormones. That means hormones, estrogen specifically, which it gets absorbed through the skin, as opposed to oral, which is taken via the mouth. The big difference between that is oral estrogen is metabolized through the liver, whereas transdermal isn't. And when estrogen is metabolized through the liver, it kicks off some clotting factors made in the liver as well, and that can potentially increase the risk of a clot. Again, it doesn't mean that oral HRT is bad. It doesn't mean if you take it, you will get a clot. It just means that for patients who are perhaps at a higher risk of a clot, for example, if they were a smoker or they had a personal or family history of clots, we might choose transdermal as a safer alternative. And then estrogen versus estrogen plus progesterone or progestogen. This depends on whether or not a woman has a uterus. So estrogen is the hormone which we need to use to treat the symptoms. But estrogen given by itself causes the lining of the uterus to grow. And if this happens continuously over a period of time, this increases the risk of endometrial cancer. If we combine estrogen plus progesterone in a woman with a uterus, it stops that from happening. And then lastly, systemic versus local HRT. So systemic HRT is HRT given orally through the skin. It's, has an effect over the whole body. Local estrogen is given for vaginal and bladder symptoms only. So that would be a pessary or a cream, which is inserted vaginally. It's very effective at treating the genitourinary symptoms, but it will have no impact on the other physical or emotional symptoms. Local estrogen is extremely low dose. It's extremely safe, and almost all women who are in menopause and have genitourinary symptoms can take it. So it's all well and good knowing what HRT is, but it's also important to know who can take it. So HRT is indicated for the treatment of symptomatic women in perimenopause and menopause. So if you were having symptoms that are bothering you, a lot of people say to me, well, how many symptoms should I be having? Or how bad should the symptoms be? Really, it depends on you. Every woman is different. Every woman will experience her menopause differently. You might have 1 or 2 symptoms and those are a big issue for you. You might have 10 and they're not a big issue for you. But if you are having symptoms which are impacting you in any way, those symptoms could be treated with HRT. We also know that HRT should be prescribed for women who go into early menopause or who have premature ovarian insufficiency. Early menopause is defined as going into menopause before the age of 45, and premature ovarian insufficiency is before the age of 40. These patients are at a higher risk of developing osteoporosis and cardiovascular disease as a result of the estrogen deficiency. And so in these women, we offer HRT to replace the hormones they would have naturally had up until the age of natural menopause, which is around 51. Surgical menopause is when a woman's ovaries are removed. This might be part of as part of a hysterectomy, or it might be done as a separate procedure, an oophorectomy for things like in women who are high risk of getting ovarian cancer. Again, if this happens in women who are below the age of menopause, we want to replace the estrogen that those ovaries would have been producing to prevent the risk of osteoporosis. And then it can actually be considered as treatment for osteoporosis in symptomatic women, so women symptomatic of menopause under the age of 60. The big kind of no's for HRT, so who can't get HRT? This is women who've had a personal history of breast cancer and some types of ovarian cancer. Look, this is a bit nuanced. We do have patients who have had breast cancer before and they're having a lot of symptoms. They come and see us and we have a discussion around it, but it's very much weighing up risks versus benefit. And, when we're looking at this category, the yes category, we know that the benefits significantly outweigh the risks. And so it's very safe for these women to take. In this category, the benefits likely are outweighed by a significant risk. For a woman with personal history of breast cancer, there's a much higher increased risk of recurrence of breast cancer if she goes on HRT. The maybe category this is where we need to decide what is the benefit, what is the risk, and does that benefit outweigh the risk, and can we use HRT? So these categories include women who are over 60 or more than 10 years after their last menstrual period, if they've had a previous clot, if they've had a previous stroke or heart attack, and if there is a significant family history of breast cancer. Again, it's not to say that these women can't get HRT. It's very much a decision which needs to be made between the patient and her doctor and looking at all the various factors. So the main benefits of HRT is symptom relief. That's the primary reason to use it, and it's the best thing that it will do is that it will improve your symptoms. And the symptoms are really what we went through earlier. So in terms of your mood symptoms, the vasomotor symptoms, the genitourinary symptoms, those will improve with HRT, musculoskeletal, and sexual function. So we know we've got good evidence. If you take HRT and you're in menopause, those symptoms will be improved. As I mentioned earlier, it should also be considered first line for prevention and treatment of osteoporosis. That would be in our kind of younger patients who go into an early menopause or who've been diagnosed with osteoporosis. They talk about a critical window of HRT, and this is really about when should we be using HRT to ensure that there's benefit from a kind of cardiovascular perspective, because we do have good evidence HRT reduces the risk of cardiovascular disease, but it must be started within that critical window, which seems to be within 10 years of the last menstrual period or before the age of 60. On my slide earlier about the kind of changes in HRT and the views to it, there was something about dementia. There appears to be a risk in dementia risk, a reduction in dementia risk when we use HRT, but we need more evidence, and it's certainly not a reason to be prescribing HRT. We shouldn't be using it, giving it to asymptomatic women to reduce the risk of dementia, because we don't have good enough evidence to say that. And then, as I mentioned earlier, benefits for early menopause and premature ovarian insufficiency. Now, what are the potential side effects and risks? Because really it's these risks which have been overstated over the years, and that's what many women are afraid of. The side effects are, the most common ones would be breast tenderness, irregular bleeding, some fluid retention, certainly not weight gain, but fluid retention, headaches, and GIT symptoms. These are often temporary, and they can be alleviated by changing the type of HRT that we use. Now, the big kind of risks around HRT would be the increased risk of breast cancer, and then potentially endometrial cancer, clot, and stroke. Now, the endometrial cancer risk comes into play if we're not using progesterone alongside estrogen or enough progesterone alongside estrogen. But if you're on a regimen, if you have a uterus and you're on estrogen plus progesterone, that risk is very insignificant. And the clot and stroke risk, again, depends on the type of HRT that we use. If we're using transdermal, it's very low. The breast cancer risk overall is very low as well. This is a graphic from the British Menopause Society, and it shows that for 23 per 1,000 cases of breast cancer diagnosed in the UK, an additional 4 cases occur in women who are on HRT. So yes, there is a risk, but it's not significant, and certainly not as dramatic as what was stated in the past. However, for some women, this risk might be unacceptable, and she may decide she doesn't want to take HRT. So in that case, for women who either can't take HRT, they're in that no category of the slide I showed earlier, or they don't want to take HRT, they might still have symptoms, though, that they want to treat and that are bothersome. And so that's when we need to look at non-hormonal therapies. And sometimes I'll say this to patients and they say, oh, but, I don't want to go on supplements. I want medication. And, I want to make it clear that there are medical treatments available that are not hormonal, but that can still very effectively treat your symptoms. So the first class of medication would be antidepressant medications. These are your SSRIs and your SNRIs. We're certainly not using these medications for women who are depressed in their menopause. We're using it because it treats the symptoms of menopause like hot flushes and night sweats. It's very effective at treating vasomotor symptoms. It can obviously have a positive mood benefit. It may help with sleep. And we typically use much lower doses in menopause for menopausal symptoms compared to the doses which are used in clinical depression. Clonidine and oxybutynin are medications which can help with hot flushes and night sweats. They don't have kind of other benefits, and they tend to have side effects that are quite unpleasant, including dry mouth and headaches. So a lot of patients will stop taking them. They find it quite difficult medication to take. Gabapentin is an interesting medication in that it's an anti-epileptic. It's also used for chronic pain. It can be used as a mood stabilizer, and again has good benefit for alleviating hot flushes and night sweats. It can have a sedative effect, so good for sleep, may help with mood as well. And then Veoza is a brand new medication which has just been released. It's a really exciting development because it's the first medication which has been designed specifically to treat hot flushes and night sweats. So these other medications have other indications, and they're used, they also have a benefit of treating hot flushes and night sweats, whereas Veoza is designed to work in the brain. It stops hot flushes and night sweats from originating, and it's a great option for women who are not able to take HRT. Under medical therapies, I've put psychotherapy and CBT as well. CBT is cognitive behavioral therapy. We have really good evidence for this in terms of helping with hot flushes and night sweats, and help with mood and sleep as well. CBT is a specific form of psychotherapy, kind of helping with reframing thoughts around events, and a lot of women find it very useful, either by itself or in addition to these other medications. And then looking at the non-medical alternatives, these are things that probably all women should be doing anyway to support their health during this time. But for women who, didn't want to take HRT, or they felt that their symptoms were mild and they wanted to manage it from a lifestyle perspective, these are things that we should be looking at. I must say, a lot of women struggle to implement these changes when they're not feeling great. Sleep hygiene is very important. When your sleep is being constantly disrupted because of night sweats, it's quite difficult to make those changes. But sleep hygiene is really around things that we all know we should be doing. Don't be on your phone late at night, going to bed at around the same time, don't drink coffee too late in the day, just optimizing things to make sure that you have a better sleep quality. Weight management and diet, it is important to maintain a healthy BMI during this time. Women's risk of cardiovascular disease increases when she goes into menopause, and so we want to try and reduce that by managing kind of lifestyle factors as well. The best kind of diet is probably a Mediterranean type diet. So that's lots of brightly colored fruits and veggies, lean protein, healthy whole grain carbohydrates, good fats, and a reduction in really processed and refined carbohydrates and sugars. And then stress management, this is something which is much easier said than done. They talk about, doing things like yoga, meditation, breathing exercises, all things to help reduce stress in the moment. Like I said, easier said than done. Supplements is a big one. If you go into any health food store and you ask for something to take for menopause, there are almost hundreds of options available. A lot of them at best won't work, or at worst could have some harmful side effects. So, I'd be cautious of the wide range of supplements that are available. I always recommend my patients take vitamin D, especially during the winter. We just don't get enough sunshine, unfortunately. And omega-3s are quite helpful as well if you're not getting kind of 2 portions of fatty fish a week. Otherwise, you don't need to be buying hundreds of expensive supplements. Acupuncture, a lot of women will anecdotally report that it helps their symptoms. It's unlikely to do harm. So, if this is something that made you feel better, there's no issue with using it. Although the actual data in terms of efficacy is quite sparse. Cold exposure, this is, when I moved to Ireland, I'm from South Africa. When I moved to Ireland, I was quite amazed at how many people were swimming in the freezing cold sea. And I noticed it was a lot of women as well. Interesting, they've recently released a study in the UK, which showed that women who regularly sea swam had a reduction in menopausal symptoms, or perceived reduction. So there's definitely something to it. I think it's a big social thing as well, which is, really important as well from a lifestyle perspective. But again, as long as you're dressing warmly afterwards, you've got your tea and your dry robe, it's probably unlikely to do harm. It could be a nice thing to add in. So in summary, menopause is not a disease. It's a natural phase of life. But if these symptoms, or if this phase is accompanied by bothersome symptoms, they should be treated. HRT is the most effective treatment. And while HRT has been thought of as very good and then very bad, kind of somewhere in the middle now. And we know that it's a safe, effective option to be used, although it certainly shouldn't be used solely for the prevention of disease. And there are good alternatives available for women who can't or choose not to take HRT. Thank you.
Genevieve, thanks very much. It was a really interesting talk. And again, you answered, I think, a lot of people's questions in that. But we have a few questions have come in. First from Paula, can HRT be used to treat high cholesterol, which manifested post-menopause, or is it just better to take the statins?
So cholesterol levels can definitely increase postmenopausally, but statins are still the preferred way to treat them. HRT is not indicated to treat high cholesterol.
Okay, lovely, thank you. How long can you stay on HRT for? And what happens if you do stop? Do you then go through the menopause again? Is it possible to stay on HRT into your 70s?
So in theory, you can be on HRT for the rest of your life.
Okay.
Previously there was a kind of this cutoff. You can only be on it for 5 years or up to the age of 60, and that's changed. Women can be on it for as long as they're getting benefit from the HRT and there are no side effects or major health issues that arise. If you come off of HRT, you're not going to go into menopause again. So really the principle of HRT is to treat the symptoms during menopause, but once you go into post-menopause and those symptoms significantly reduce, at that point we could take you off of HRT and your symptoms shouldn't come back because you're now in post-menopause.
Okay, thank you. At what point should I consider starting HRT?
Patient dependent, really around symptoms. So if you are getting symptoms in your mid-40s and they're bothersome, consider it. If you're only starting to get symptoms in your early 50s, consider it. But it's really around, rather than age, go by symptoms and how bothersome those symptoms are for you.
Okay. And what are the potential effects of menopause on reproductive health, and are contraception options still available?
So your fertility declines as you go through perimenopause because ovulation, your egg numbers reduce, ovulation becomes sporadic. There's pregnancy is not impossible in perimenopause. It's about a 1% chance of falling pregnant. And then menopause can't fall pregnant. They say that you should still consider using contraception up until 1 year post your last period. So contraception is still advised. And the best options would be condoms, the progesterone-only pill, which can be used up until age 55, the Mirena coil, or a vasectomy if your partner is open to that.
Okay, thank you. And what's the role of a pelvic floor physiotherapist when it comes to menopause?
So that's really important. As I mentioned in the symptoms, there are a lot of genitourinary symptoms that occur during perimenopause and menopause, and a lot of changes in the vagina, the vulva, the bladder, the pelvic floor, and women might start to experience bladder issues, but also kind of bowel issues as well, including things like fecal incontinence. So any bladder issues that are bothersome around that time, a pelvic floor therapist can be incredibly helpful and help you to know which kind of muscles to engage, which ones to relax, and how to manage those symptoms rather than just relying on medication.
Okay. Genevieve, thank you so much for joining us tonight.